Hello and welcome back to the Clinical Research Consortium. I'm Len Matheson. Today's presentation is part 2 of the history of SWAGs, or Structured Work Activity Groups. I will be integrating the conceptual context and the clinical context in which we use SWAGs and other situational assessments. If you're a vocational evaluator or an occupational therapist addressing work disability, you're going to be very excited about this approach. Today's talk is also going to give you a tremendous feeling of confidence in the value of your participation on the interdisciplinary team. The plain fact is that you bring crucial information that can't be obtained in any other way. So let's start with the conceptual context, the stage model of occupational rehabilitation. There are 8 stages, beginning with the illness or injury, where the team addresses the person's pathology. The team progresses methodically through the 8 stages as we help the person move from being a patient to being a client to being a worker. Now, as you look at this model, you're probably saying to yourself, wow, that's complex. And you're right, it is. But this is what the patient, client, worker is dealing with. The person who comes in with a head injury or spinal cord injury or a serious disabling disease diagnosis is the same person that needs to progress through all 8 stages to get back to fully participating in society. Situational assessments, of which the SWAGs are an excellent example, help to bridge from functional limitation to occupational disability to vocational feasibility to employability. To the degree that you have expertise with situational assessments, the data you collect will be senior to the data collected at the earlier stages. Let me put that another way. Although the surgeon and physician and neuropsychologist have terrific skills to address pathology and impairment, their data can only infer the person's status at the later stages. The data that you collect with situational assessments are a better predictor of the person's eventual earning capacity simply because they're more proximal. In today's lesson, I'm going to help you understand how to develop work-relevant professional opinions by describing some of our experiences at the Downey Hand Center. The Hand Center is where it became clear that the biomechanical, cardiovascular metabolic, and psychophysical systems work together to limit the person's work capacity. Downey is where we began to develop methods to identify the most limiting system. At the end of this lesson, I'll provide some additional references if you'd like to continue your studies. At the Downey Hand Center, plastic surgeon Dr. Gary Brodie led a wonderful team of occupational therapists, including Lois Barber and Kay Golgi. In 1979, I was invited to set up the nation's first upper extremity work hardening program, where we invented several situational assessments that are in use today, including the pipe tree, birdcage, and jailhouse. To determine which situational assessments to use and how to configure them, we relied on a psychophysical appraisal method using the RISC tool sort. Let me show you the tool sort and then explain how working with hand injuries provided an excellent opportunity to develop psychophysical appraisal methods. The RISC tool sort was a deck of cards sorted by our patients to help them communicate to us what they would be facing as they attempted to return to work. Remember from the first video lesson that it's important to create shared knowledge bridges between rehab clients, rehab professionals, and employers. We don't have the same knowledge base. Each of us is different. The tool sort was quite helpful bridging these gaps. I clipped pictures from tool catalogs and pasted them onto multicolored 5 by 8 inch cards, linking the tool family to the color of the card, and putting the typical physical demand characteristics demand level of the job in which each tool was found on the back of the card. I selected tools and cross-referenced tools to their jobs using the Department of Labor Job Analysis Handbook. In the JA Handbook, you'll find the Materials, Equipment, and Work Aids, or MTEW system that helped me link tools to jobs. We had our clients sort the deck twice. The first sort was to identify tools that are actually used in the client's jobs. We had clients put the cards into 3 stacks, those which were never used, sometimes used, and often used. In this way, the client was able to identify for us tools that we needed to pay attention to. It's a simple fact that the demands of many work tools are only vaguely known by therapists and physicians. Sorting the cards was a terrific communication exercise, putting the client in the position of educator and rapidly increasing the knowledge of the therapists and physicians. The second sort involved only those tools that were used sometimes or often, using this 5-level sort of the client's perception of his or her current limitations. We use the client's responses to the 5-level rating scale to help determine which situational assessments to use and which work tools would be used within the situational assessment. Most of the situational assessments could be conducted with different tool sets, depending on the needs of the client. By the way, the don't know category turned out to be a general indicator of ambivalence about returning to work that fit in with our approach to the symptom magnification syndrome as being a set of learned behaviors. More about that in other video lessons. The second sort was part of a structured interview segment in which the therapist asked, "As you see yourself using this tool, how restricted are you?" After the second sort, the therapist started with the slightly restricted tools and asked, "As you see yourself using this tool, what's the most important problem?" So, did the risk tool sort provide us with useful information? Well, absolutely. It was fantastic. It was safe and valid and practical and provided good utility. But what about reliability? Well, because it was a self-report measure, we had concerns about reliability. Was the client being truthful, let alone accurate? It's extremely important to challenge the reliability of self-report assessments, especially in litigated situations. And 90% of our clients had attorneys, so we knew that our clinical work would be scrutinized closely and that it was always possible to be called to testify. But here is where the professional's training comes to bear, and why the Downey Hand Center was an excellent opportunity to develop this new psychophysical appraisal method. Let me explain. When we look at the foundations of a person's work capacity, we find that their performance is dependent on the integration of 3 human performance systems: the biomechanical system, the cardiovascular system, and the psychophysical system. These interact to determine the person's performance, and one of these is always limiting. Keep that in mind. So in rehabilitation, it's always necessary to ask which of these systems is most limiting. It's never true that there isn't a most limiting system, and it's always true that we get the most bang for our buck in rehabilitation by successfully addressing the most limiting system. The interesting thing about hand injuries is that the cardiovascular metabolic system is usually the least limiting system, usually by a great degree. There are, of course, exceptions to this, but generally speaking, this is the case. So what this allows us to do is to separate out the cardiovascular metabolic, leaving a much less complex problem, determining whether or not and to what degree the psychophysical system is dominating the biomechanical system. And in rehabilitation that involves disability as a consequence of pain, this is usually the most productive approach. We can help the hand-injured client make important improvements biomechanically, but pain is often an important limiting factor, giving rise to a host of psychophysical limits. Our brains are designed so that pain is a safety signal to help us survive. The psychophysical domain extends beyond pain into motivation and fear and expectations, but pain is the most easily accessible, the most obvious. In rehabilitation, we do our best to help the client negotiate with his or her pain symptoms at the same time that we are helping him or her to achieve subtle but important modifications of these cognitive self-appraisals. So how do we do this? Well, by asking, as you see yourself using this tool, what's the most important problem? And then by applying the hand therapist's knowledge of the biomechanics involved, we begin to help the client make an accurate self-appraisal. In this way, the professional is assisting the client to address limitations born out of fear or catastrophizing beliefs. When a functional limitation is greater than what can be attributed to biomechanics and anatomy and physiology, we need to look at the psychophysical domain. And so, as the therapist went through this process with the client, asking about specific functional limitations, patterns begin to emerge that we can call work function themes. Work function themes guide our participation in work. WFTs are what help us stay safe, avoid errors, and maximize our productivity. The logical consistency of WFTs provides the basis for reliability testing of the sort results in subsequent situational assessments. In later years, we went on to develop other methods of mathematically addressing reliability that were made possible with the Apple II personal computer when it became available. My nephew Tyler Johnson and I developed a method to analyze work function themes and look for consistency in responding. This is an early version of a spreadsheet that laid out the work demand factors for several of the tools in the sort. We combined the work demand factors with self-rating information collected by the therapist during the interview with the client. This gave us a mathematical method to grade the client's work function themes and measure consistency in responding with a high level of precision. This really helped to address the issue of reliability. I'll describe this in more detail in later video lessons. Because most of our work was being done with clients who were represented by attorneys, we had to confirm that the tool sort self-report data provided reliable information. When we were required to go to court and testify, our opinions were routinely challenged by attorneys. At first, because we were dealing with self-report data, we were somewhat shy about this. But we soon realized that because we were marrying self-report data with situational assessment data, and were also doing a professional audit looking for logical consistency, we actually had extremely reliable data. And because our data were specifically tied to the client's job, we had the most valid data of all the caregivers and experts. Combining the self-report data with the situational assessment data put our professional opinions in a very powerful position. Very quickly, Dr. Brodie and all of the other physicians began to routinely defer to us for return-to-work recommendations because our data were much more specific and job relevant. Although we were frequently challenged in court by attorneys who disagreed with us, our opinions were always upheld by the court. We never had an opinion that was successfully challenged. So, how has this moved us along the SWAG development path to where we are today? Well, combining self-report data with work sample data and situational assessment data is an important strategy that we adopted for the DCAT and other SWAGs that we developed at the Washington University School of Medicine in St. Louis program in occupational therapy. This is a powerful strategy to measure executive dysfunction in the workplace. In the next video lesson, I will present a complex case study in which we combine self-report data with a structured work simulation developed by the Work Evaluation Systems Technology Company, also known as WEST, in work that we did at Casa Colina Hospital for rehabilitation medicine. I hope you'll come back. So, thank you for trusting us with your time. Please subscribe to this channel to get notice of future video lessons. Here are 2 peer-reviewed bibliographic references that I think you'll find useful. They're available on our website. Take care now.